Hi, everyone. Thank you very much for being here. I'm Margo Edmunds, and I'm a Vice President at Academy Health, and I'm very glad to be with you today. I'd like to thank Dr. Resnick and Dr. Slevin for the invitation to talk with you about the Academy Health perspective on telehealth and telerehabilitation. By way of background, my career started in clinical practice at the Behavioral Medicine Clinic at Johns Hopkins, where I teamed with physical therapists in rehab medicine working with chronic pain patients. For most of my career since that time, I've been working at the intersection of health policy research and health IT, including telehealth. So this presentation will be a blend of perspectives relating to research, policy, and practice. I'll be starting with some background on Academy Health, and then I'll talk about some of our recent telehealth projects. Then I'll talk about research needs from the perspective of different stakeholders, including patients, providers, and payers. And then I'll close by talking about the implications of current trends and approaches for telehealth research, policy, and practice. Academy Health is a national nonprofit organization and a professional society that focuses on health services and health policy research. Our mission is to translate evidence and research into policy and practice. Our strategic plan focuses on 3 areas: health systems improvement, science innovation, and diversity, equity, and inclusion. We have individual members, organizational members, and interest groups. We offer national conferences such as our annual research meeting and a national health policy conference, and a lot of smaller convenings. Our conferences are what we're best known for, but a large part of our work is actually stakeholder engagement through health policy research, program management, and technical assistance. And our work is supported by federal contracts and grants, by PCORI, and by several foundations, particularly the Robert Wood Johnson Foundation. So that's a snapshot of Academy Health. Our work in telehealth is mostly in the evidence generation and translation space. We do environmental scans, synthesis reports, for example, doing a review of the literature and translating it into a one-pager for a policy audience on Capitol Hill. We do research and policy agenda development through convenings. We also do rapid evidence reviews. And as you're probably aware, we have a telehealth track in most of our conferences where a lot of other presentations are made by our members. We also have fellowship programs with embedded researchers with a variety of health systems around the country using the Learning Health System model. And the largest current project is with the VA on learning health system competencies, and Dr. Resnick is a member of the advisory group for that work. So I'm going to begin today by talking about a project that was funded by the Kaiser Permanente Institute for Health Policy. The project was designed to develop a research and policy agenda for telehealth that had a very broad scope. It started in late 2015. It was initiated by Dr. Reed Tuckson, who was the president of the American Telemedicine Association at the time, or ATA. So we convened members of Academy Health who are doing health IT work, the ATA policy team, members of the Kaiser Permanente policy team, and representatives of an association of insurers who focus on medical malpractice. And by the way, there are virtually no telehealth claims for malpractice. We had about 25 people together for a day, and Reed facilitated. He had promised his board at ATA that he was going to produce a review of the evidence on telehealth. So the policy context for this work was that AHRQ at the time was doing a technical review on telehealth consultations through the Evidence-Based Practice Center at OHSU, and they had a lot of limitations on what they could look at. So I was on the technical expert panel for that report. We shared information with the OHSU team and were more free range, I think, in our ability to challenge ourselves to get everything about the field onto one slide. So this format is based on the Donabedian framework and structure. It talks about, from the left side, we talk about the policy context. In the middle, the process. We talk about the delivery system, both at the population health level and in terms of telehealth modalities in the green in the lower part of the slide. And on the right-hand slide, we talk about all the different outcomes ranging from prevention to improving access and quality of care through efficiency, looking at healthcare utilization changes, and also looking at cost savings. So this framework was presented at the ATA conference that year. It was published in an AHRQ-funded journal called eGEMS, which has since sunsetted, but the article, if you're interested, is still available online through the National Library of Medicine, and the reference is at the end of the presentation. So at the time we did the research and policy agenda I just was talking about, Reed, Tuckson, was also working with the AMA executive team and leadership there. He had a sense of urgency about summarizing the evidence base for telehealth in a way that would convince the AMA to support increased involvement of physicians in telehealth. This was 4 or 5 years ago. And as you'll recall, there was a lot of reluctance at that time about doing virtual visits. The technology was expensive. It was hard to integrate into workflow. Payers had a lot of restrictions on what was covered. So this article was the result. It was published in 2017. It's gotten a lot more attention in the past year. I think we know that telehealth has saved a lot of lives. The evidence base didn't really matter during the pandemic. It was full speed ahead to save lives. And we blew through a lot of the barriers that we used to think were insurmountable. But the recommendations in this paper, if you look at the bottom bullet, really focused on research needs, including understanding more about how to do clinical data integration so the providers didn't have the burden of checking so many systems with different passwords and so forth. There's also a need to understand a lot more about decision support on the patient side, as well as the provider side. And we also called for more research in real world settings and learning health system models. I think, a lot of our thinking there was that trials are the gold standard, but they're prohibitively expensive. They take a long time, and there's really a need for new research methods for learning health system studies. From an implementation science, team science perspective, integrating some of the new predictive analytics, data visualization, and other areas of expertise. Now I'm going to shift into a consumer engagement perspective. This was the summary slide from a PCORI Engagement Award on shared decision-making. This is a project in which telehealth is embedded and assumed, but not mentioned specifically. It's about shared decision-making. It assumes an electronic environment. And if you look at the lower left-hand side of the graphic, this is our depiction of the clinical encounter with the patient or person on the left side and the clinician on the right side, and all the domains of information that each one of them brings to the clinical encounter, to the moment or to the moments in which they're interacting with each other. We had a small advisory group for this project that was chaired by a patient and a mobile health researcher. It had a balance of researchers, consumers, health systems folks, and policy people. And we also had a user experience expert who designed this infographic, Jeff Corcoran. We convened 2 workshops in DC and Sacramento for a total of 50 people. They went through the same process of a facilitated generation of recommendations. And this is a summary of the recommendations that came from that group in terms of future research. This is a synthesis of the recommendations that were made across 4 papers that have been jointly co-authored with the advisory group and are currently under review with 2 peer-reviewed journals. A lot of the focus here, again, remember that we were talking about the consumer side of the care experience. So we made recommendations about more research focusing on consumer technology literacy and preferences based on low vision, low auditory capacity, preferences for touch screen and other kinds of modalities. You can read down the list, but I think that one of the things that we really came away with was that in order for all of these areas to be researched and eventually integrated into clinical care, it's going to require change management at the systems level. This next study took place last spring at Academy Health. It was a follow-on from the National Academy of Sciences, Engineering, and Medicine report on COVID-19 that was released in the spring of 2020. The purpose of this study was to convene C-suite and health systems leaders to develop some recommendations for funders of health services research about their information needs. It was based on the report that I just mentioned, which had focused on research needs. This particular convening focused on health systems experts, mostly C-suite, some federal officials. Some, but not all, were telehealth experts. And there were about 50 of them. They convened for 90 minutes, did some brainstorming, and used a co-digital platform to curate their brainstorming. They revised the list, went through an iterative process of online voting on the priorities for each of the areas of recommendations over a couple of week period. And then they released the report in May of 2020. So the whole course of the study was about 2.5 months. The recommendations in that area focused on 5 areas. And one of the areas was research priorities for technology, data, and telehealth. They focused on having a better understanding of the impact of different kinds of care types. They also, I think from the operational perspective, were concerned about what kinds of bandwidth and information systems will be required. And they also were interested in having more research on how to tailor services for diverse patients, not only by age and gender, but also by race and ethnicity. So let's fast forward. That was May of 2020. This is now the end of the summer of 2020. This is a summary that came out from the AMA practice management team of all of the changes that CMS had made to payment policy to encourage clinicians to adopt telehealth if they weren't already doing it during the pandemic. And I think that this really shows the power of policy levers to change practice. So most of these areas, I'm sure those of you who are in clinical practice are familiar with a lot of the changes that were made this year. I think what will be most interesting will be to see how these payment policy changes evolve after the period of emergency. So given what we've talked about so far, this is my take on, from the patient perspective, what some of the emerging trends are and opportunities for research. The first is really, I think, that what we used to call the empowerment, but the value of the consumer voice and of person-generated health data, or PGHD. That's kind of an awkward acronym. It evolved from patient-generated health data. And I think that in our work on the PCORI grant that I mentioned a few moments ago, our patients or consumers really felt that they wanted to be called persons. It was more comfortable for them, and we've adopted that language at Academy Health. So there were some key areas that PCORI study really brought out. One of them was about who owns the data that are generated by patients from remote locations, wearable devices, and so forth. Another area that I already mentioned was needing a lot more understanding of how to use assistive technologies. And then I also wanted to mention that there was a study currently going on by funded by the Hartford Foundation at Johns Hopkins, working with Open Notes to focus on how caregivers and patients can have access to consumer portals and to their own electronic health record data. Another area that I believe is going to be growing in support from ARC and PCORI is on shared decision-making and clinical decision support tools. And another area, certainly with the new administration and the executive orders that have been released, are about racial equity and about access to technology. You may be familiar with the term digital divide. Some of us are trying to move toward flip it on its side to talk about digital inclusion as a goal, not only at the individual level, but also at the community level. So here's where I think the research opportunities are going to be for health services research and learning health systems moving forward. We've talked a little bit about alternative payment models coming out of CMS. Typically, they fund test projects with 10 to 20 states or provider groups to try out new models. A lot of these models are now focusing on how to integrate information about social and economic risks, known as social determinants of health, into electronic health records. Another emerging area, I think, for those of us who work in team-based care is going to be how, as we move from fee-for-service to more integrated payment, how we're going to do billing for team-based care. That's something that I think will be paid more attention to in the future, perhaps by professional organizations. Another area of concern that's getting increasing attention, these are kind of operational areas where real-world research can be incredibly helpful, is on clinical workflow and technology integration. We're also beginning to see a lot more interest at CMS, for example, in health information exchanges and in the interoperability of different health systems using different electronic health record systems and other kinds of data systems to share information. The field that deals with that area of software is called informatics. It's been around for about 40 years. A lot of people are not familiar with that term, but information technology and informatics workforce I believe is going to be really increasing in the next few years. And so please keep an eye out for that. We also mentioned the patient access to medical records being incredibly important. A lot of providers are not set up to provide patient access. That will be an area of emphasis. The Office of the National Coordinator for Health IT and the Office of the Secretary of HHS is going to be looking into that, as well as looking into human-centered design thinking. And again, all of these different kinds of changes are going to require attention to change management to make sure that the systems change is done equitably and fairly. So from the payment perspective, I mentioned alternative payment models coming out of CMS, driven by a policy desire to have high value care, what we used to call value-based payment. Patient and caregiver access to claims, clinical and encounter data through health information exchanges, I think it is kind of new to the payer community, but they're working a lot more with that from the CMS is collaborating with the Office of the National Coordinator, which is good to see. There is some concern in the telehealth space about fair competition from telehealth when people from other states can come in and see patients. That's referred to by some provider groups as land grabs. And Kaiser Health News on May 15th had an interesting article about that for those of you who are interested. Another area that I think we're going to be seeing ramp up quite a bit is infrastructure investments to improve access through broadband. There's a new FCC program, the Emergency Broadband Benefit Program, that is just in development right now. If you're interested in finding out more about what's happening with those grants, that's the information is available at the Benton Foundation website. And also HRSA has launched a rural health pilot with an $8 million investment that started in January 2021. So to wrap up, I think, it's pretty clear we're not going back. Telehealth is here to stay. We may be calling it other names. It may become simply part of the fabric of the delivery system. We know from our own eyes and our own personal experience that it improves access. It reduces travel burden both for patients and for clinicians. It provides better continuity and quality of care by improving timeliness. This varies quite a bit by health system and by provider group, but I think that there is some evidence that after the initial investments, it can reduce costs, but this is an area that certainly needs a lot more research. I'd also like to encourage this audience to think more about implementation science and learning health systems research, particularly around clinical workflow. And the value of real world evidence, as I mentioned before, is that we can learn from operational and quality improvement processes that are already in place. For example, who was able to ramp up quickly to get their telehealth call centers put into place. There's some very interesting articles winning their way through the peer review process about how health systems were able to do that this year. And we're hoping that there will be a lot more health systems who are going to begin to adopt telehealth and support the kinds of patient focus that many of us have advocated for. With regard to cost implications, I just wanted to say that anytime that you reduce costs in one place, we know that there's some initial technology investments, but if you reduce costs through improved efficiencies, the costs might pop up somewhere else. And so particularly when people have felt that they've lost income who is not getting paid, there's going to be, again, a lot of attention paid to how to be equitable in terms of cost investments in the future. So I could go on, but I think I'm at time. And so I'd like to thank you very much for being here. I'm an optimist. I think that your work in telerehab research is positioned to make a tremendous contribution to learning health systems and in many other parts of the delivery system and health policy. So this is the end of my presentation, and I'll look forward to the Q&A discussion that will follow. Thank you very much.